Hi, Dr. Brian Lamb here. I have been asked by Natasha to give you guys a lecture on pediatric dentistry, so I've arranged a few topics that we'll discuss today, and hopefully you guys will get a good sampling of pediatric dentistry and be interested in the future. So a little bit about myself. I have been a pediatric dentist for 6 years now. I practice at Gateway Pediatric Dentistry. We currently have 3 locations, one in Edmonton, St. Albert, and Sherwood Park. And I actually know Natasha because she was one of my former RDAs a few years ago, and we've had a great working relationship. So definitely any questions that you might have after today's lecture, she'd be a great resource in terms of learning more about pediatric dentistry. But I will provide my email address and my phone number if anyone is interested in shadowing or just asking questions in the future. In order to become a pediatric dentist, dentist needs to graduate dental school, apply for residency. It's an additional 2 to 3 years of training strictly with pediatric patients, special needs patients, and medically compromised patients. After the 2 to 3 years of residency, the individual has to pass the Royal College exams in order to be called a pediatric dentist here in Canada, as well as in the States. Pediatric dentists will see patients anywhere from newborns up until 18. And as you can imagine, a 1-year-old toddler is going to be a lot different than a 4-year-old, and then they're going to be a lot different from a 10-year-old, 16-year-old, and 18-year-old. So it's a huge range of patients. Their dental anatomy is a lot different. Their overall skeletal structure and growth is different. Their demeanor is different as well. And it's a huge range of patients that pediatric dentists will see. Not to say that general dentists can't see patients of that age, but pediatric dentists are just more specialized in terms of their care, their patient management, behavior management, and there's a lot more sedation modalities that they do use in regular treatment. One of the more unique things about pediatric dentists compared to general dentists is a huge component of behavior management. Many patients are coming in pretty scared, pretty apprehensive. You can imagine what a 1 or 2-year-old feels like when they come to the dentist. It's a pretty scary experience. So the goal of the pediatric dentist as well as the pediatric team is to make it a very comfortable and just acceptable environment for the children as well as the families. A lot of parents have their own dental anxieties and they often pass that on to their children. So one of your jobs as the RDA is to help welcome the children and parents and family members into the clinic with a warm smile, really calm, gentle demeanor. And we try to make it an environment so that the kids as well as the parents are able to trust us and we're able to provide a good experience, but also maintain good routine care and provide really high quality care so that patients aren't repeatedly coming back for failed treatments. And they're also not afraid of going back to their regular dentist, and that they're still comfortable seeing a dentist throughout their life. Much like general dentists, pediatric dentists do many disciplines of dentistry, including restorative, which would include composites, amalgams, stainless steel crowns, zirconia crowns, surgery, which would include anywhere from extractions, some will do wisdom teeth, complex extractions, removal of lesions, biopsying, any type of soft tissue or hard tissue lesions. We also do perio, hygiene recalls, a component of orthodontics, and there's also a really major component of sedation in our practice. A pediatric office is run a lot like a general office in terms of running multiple columns. Here at Gateway Pediatric Dentistry, we'll generally run 3 to 4 columns on a clinic day. One column is usually restorative, another column is usually new patient exams, and then 1 or 2 columns are recalls. In our office, we do employ RDAs with expanded function, so many of them have scaling and ortho modules. We also do have hygienists on our team. And the RDA's main role in our clinic is to manage recalls, new patient exams, and directly assisting us in terms of procedures. The role of our RDAs in our clinic range anywhere from jumping in and out of steri or spending a whole day in steri to taking new patients back, doing recall exams, as well as prophies and cleanings. You're taking radiographs, and we do have many assistants that do have their scaling and ortho modules. So they'll be helping quite a bit in terms of scaling for our recalls, taking impressions, or removing and placing in appliances. And then most importantly, assisting us dentists directly for procedures. Our RDAs also assist us when we are in the operating room. Seeing patients while they're asleep under general anesthesia is a very large part of our practice. As you can imagine, trying to do restorative work on a 2-year-old is quite challenging. We also get a lot of referrals where the patients have a whole mouthful of caries, so trying to do anywhere between 12, 16, 20 teeth at one time in the clinic is almost impossible. So not all of our RDAs are assisting us in the operating room, but many of them are, and that's a huge component of our practice. One of the differences between general and peds is that you have the patient in the chair, which is our pediatric patient, but we also allow parents in the back, and the parents are spending a lot of time with you while you're waiting for the dentist to come see the patient. And you're the first face and the first interaction that the parent will really have other than admin. And they're often asking you questions, anywhere from like what's going on with their child to routine dental care to dental specific questions such as whether or not you should be using fluoride on a 1-year-old or a newborn. Is it normal for kids to have cavities? How often should you be brushing or flossing or showing them techniques? So, your demeanor has to be quite good. You have to be very good with people. And unfortunately, you always have to be on. Like you can't really be in a bad mood when you're working with kids because kids will definitely read your energy. And you don't have to be great at working with children. It's something that you can develop as a skill set, but you just have to know that if you're someone who is a little bit rough around the edges and you don't love working with children, it might be a hard field to jump into. There are many different materials and treatments that you're going to be learning in school. And the nice thing about pediatrics is that you're doing very similar things almost all the time. So you're getting really good at certain procedures. In our office, we mainly use composites or resin modified glass ionomers for our restorative, but there are pediatric offices that still do use amalgam. You should be proficient using rubber dam. We don't personally use it at our office, but it is used quite often in private practice. We use the isodry system, which could also sometimes be a challenge for some children. We place a lot of stainless steel crowns, but we're also using a lot of zirconia crowns now. So the difference there is stainless steel is silver in color, zirconia is white. A lot of parents do prefer the aesthetics of it. And there's a different method on how you place the crowns as well as different ways to mix the cement. So it's quite important to be proficient at that. We also do a lot of ortho, a lot of phase 1 ortho. So space maintenance, maxillary expansion, different treatments to help influence growth so that children aren't stuck in crossbites or they aren't having to deal with many years of orthodontics in the future. We also deal with a lot of habit appliances. So a lot of kids do suck on their fingers or a pacifier as they get older, and our goal is to help them get off those habits so that they don't have major spacing and skeletal issues as they grow older. In terms of mixing cements, I was going to go into quite a bit of detail on this, but I was told by RDAs not to yet. But you'll want to know how to mix cements. You'll want to know when to use IRM, MTA. We do a lot of nerve treatments or pulp treatments, so a lot of pulpotomies and pulpectomies. And we do a lot of surgery as well. So it's there's a lot of stuff that you can do and you assist with pediatrics, but it's definitely very catered to like a very specific niche. One really common feature of pediatric offices is the use of sedation. So we use anything from no sedation, just local anesthesia for procedures, to nitrous oxide, which is also laughing gas. Laughing gas is nice because it's a very mild sedative that just helps the patient relax. It also introduces a component of pain management so that oftentimes we can do basic restorative without any freezing, which a lot of kids really prefer not to have. We don't do it at our office, but it is common in other offices. IV sedation, which is sedation with medication delivered through an IV, as well as oral sedation, which is a medicine that you would drink. The patient would be sedated anywhere from 20 minutes to several hours, so you'll have to be able to know management of those types of patients. And then also general anesthesia, which we do in an operating room. As an RDA, you should at the very least know your BLS and your basic CPR, but it's always good running through emergency procedures with your office, or learning that in addition to your regular training, because you just never know when you're going to have to respond to an emergency in the office. But it's also a great skill set to have just in your regular life, just in case a family member or a friend or even someone in public ends up passing out and you're having to deliver, life-saving action. Children don't necessarily have great attention spans. They also don't really have coping mechanisms that help them bear down. The difference with a lot of adults, if you tell them that they just need to sit still for another 5 minutes, or, if a part's uncomfortable, most adults are able to cope with it. Children usually don't. So you have to work really quickly with kids. Sometimes you only have, a few minutes to actually get a procedure done. So you have to really be quick on your toes. You got to really be able to adjust on the fly. So let's say if you set up for a composite and all of a sudden the composite is ending up becoming a pulpotomy and you need to do a stainless steel crown, you need to be ready to pivot really quickly. Sometimes you don't have that extra time to reset up. So you have to get really quick at it, which is fine. You're not going to be quick right when you start, but it's something that you will get better at and you will adapt to once you're in a pediatric office. I discussed this a little bit earlier on, but unfortunately you can't really come to the office in a bad mood when you're working with kids. They really feed off your energy. And if you're, tired, or if there's other things affecting you in life and you're just not having a great day, you can't necessarily, treat a child poorly or, be in a bad mood. And it might sound silly right now, but once you start working full time, you'll definitely have the days where you don't feel like yourself and you don't really feel chipper. But unfortunately, you kind of just have to always be on when you're at work. And the kids will read off you, unfortunately, same with the parents. And the difference is, like, sometimes with adults, you can kind of be a little bit harsher with them. But with kids, you have to be really positive, a lot of positive reinforcement, a lot of encouragement. You're going to see a lot of kids that aren't overly well behaved, and you'll probably want to judge them or even judge the parents on how uncooperative or how poorly they listen. But unfortunately, that's just not a thing that you can really do in peds. And it's something that you will kind of have to adapt to and learn. If you're a person that you just don't like working with kids, and you're going to become a work sour on some certain days, peds might not be a thing for you. But if you like working with kids, you'll feed off their energy, and it makes the day go by really quickly, and it's pretty rewarding as well. Being a team player is a really important feature for any RDA. Unfortunately, you probably won't be working with just one dentist or just one other staff member. You'll likely be working with a small team or a large team. And like any team, everyone needs to play their equal role. We expect a lot from our RDAs. It's a very fast-paced environment. We expect everyone in our team to be pulling their own weight and to be picking up the slack, especially if, someone becomes sick, or if we're running a bit behind, you might be taking your break a little bit later, eating your lunch a little bit later. But it's sometimes nice seeing how hard your teammates work, and it makes you want to work harder as well. But being a team player is so important to becoming an RDA just in peds. And once you're in a good team, you'll see how everything flows and how efficient the day goes when everyone is pulling their equal weight. And you can always tell when someone isn't, because it makes everyone's day a lot harder. So a huge component of just being an RDA in general. Not specific to peds, but as you start working, you're going to have to really get to know how your dentist likes doing certain procedures. Different dentists will like using different instruments, different burrs, different materials for different types of procedures. Sometimes you'll be in an office just like ours where there's 5 different dentists and possibly 5 different ways to do the same thing. But as you get to know them and you develop a working relationship, as long as you're attentive, you'll start picking up different trends and you'll get to know how your dentist works, and it makes the procedure go way more smoothly and everything will flow a lot better if you know what they're hoping for next. Unfortunately, I'm not like the greatest communicator, so I don't really use my words that often, but thankfully our RDAs know me so well that I'll look at them and they'll know which instrument to be passing me or which material. I have been working on it. I'm trying to communicate a lot better. It's one of my New Year's resolutions, but I'm so thankful for how attentive they are. And yeah, this is just specific to peds. You'll want to really pay attention to your dentist regardless of which discipline you're practicing in. You do not need any additional training to work in a specialty office. So if you were interested in peds, you can go straight into a pediatric office straight from school. But you can also go into any other specialty office without any additional training as well. As an RDA, you can actually have a lot of different roles in an office. So for example, in our office, one of our RDAs, she didn't love the component of assisting in dentistry. So she's actually one of our full-time admin members and she's amazing at it. She's kind of the first face you see when you walk into the clinic. She's also one of the people that you talk to on the phone and she is amazing at it. But I don't think she ever thought that she'd be going into full-time admin when she was in school. We also have 2 RDAs as well that practice as RDAs. Now they are treatment coordinators and they've also become managers of our office. So there's definitely a lot of room to grow within offices as well. And don't think that just because you've picked a certain role or a certain office that you're stuck there for the rest of your career. Some assistants have worked at many offices before they found our office. And many of our assistants have been at our office for a while and they ended up going to different offices as well. So don't ever think that you're stuck in a position that you're not 100% happy with or comfortable with. As a pediatric dentist, we also see a lot of special needs patients. So we see a lot of patients on the spectrum. We see a lot of kids that are like extremely afraid of everything. So making dental visits happy it's quite a challenge at times. But our goal always with our families and our kids is to eventually have them come in independent of their families and have a fairly normal dental routine. So we have a lot of patients that are on the spectrum, a lot of Down syndrome patients that are very afraid of us initially. And it takes years for them to get comfortable, but we have many special needs patients who come in as teenagers and they're able to get their teeth cleaned, they're able to get x-rays. A lot of them are able to sit through restorative. And yeah, our goal is for them just to have a very normal dental routine when they come in. And we don't graduate any of our special needs patients, so we do see them of all ranges of age. We don't kick them out when they're 18. We also see a lot of medically compromised patients. So unfortunately, a lot of them cannot go to general dentists just due to their medical conditions. We have access to the stollery as well. So if there are any patients that do need extensive dental work or surgery, we have access to the stollery, so we're able to bring our special needs patients there for their dental care. Many of our patients are referred to us from general offices. A lot of general dentists will try to do peds patients in their office, but a lot of them don't do any type of sedation. So oftentimes when patients are referred to us, we can't just do local anesthetic. So the 2 common options we have would be nitrous oxide or laughing gas. And these are for patients that are able to sit in the chair for radiographs. They're pretty well behaved for the most part, but they just need that extra bit of sedation to help them feel a little bit more comfortable and better. If it's extremely extensive surgery that we know will take us at least a couple appointments in the chair, oftentimes parents will opt for their patients to go completely asleep with general anesthesia. General anesthesia, the patient is asleep completely for about 45 minutes to an hour. And we do that at the Alberta Surgical Center or at the Stollery Children's Hospital. And if they're asleep, we're able to get everything done in one appointment That's where we'll do full mouth rehabs. And it's really nice for parents from out of town just because it's one trip, it's guaranteed to get done, and then they go home the same day. Oftentimes, parents will ask us what's the point of working on baby teeth when they're just supposed to fall out. So, primary teeth, there's 20 of them in total. The incisors, they fall out usually around 6 to 9, but the primary canines and molars, they don't fall out until about 10 to 13. So, as you can imagine, if you have caries early on, those caries will get worse. Patients will start feeling pain quite quickly on them. And if they get large enough, you'll start getting abscesses and you start prematurely removing teeth. One of the issues with extracting teeth is the primary teeth act as natural space maintainers for your adult teeth. So you ideally want to keep them as long as possible. They also are there for functionality. So if you don't have primary teeth, you're not going to be eating very well. And also the aesthetics of it. Yeah, you'll be losing teeth, usually, 6 to 9, but you don't want to be taking out teeth early. And a lot of parents are actually really quite concerned about the look of their children. So you don't really want to be extracting teeth prematurely. Dental infections are quite common, and that's one of the major reasons that we'll see children. Cavities, I always tell parents they're essentially just holes in the teeth caused by bacterial invasion. Once the bacteria gets past the enamel into the dentin, that's when we say it's necessary to restore teeth. Once that bacteria gets into the pulp chamber of the tooth, that's when you start getting that toothache pain, and we'll start seeing localized abscesses around the gum line. But we'll often see facial cellulitis, and from that point it gets quite dangerous. So we always prioritize trying to fix infections as soon as we can, really emphasizing continued treatment just to help prevent this type of infection from happening in the future. Unfortunately, when parents leave the hospital, they're not really given an instruction manual on how to take care of the teeth, and they don't really get a whole lot of dental education at the hospital. So we always recommend seeing the pediatric dentist when you're 1 year of age. And your role as the RDA is to educate the parents on how to maintain good hygiene, diet habits. There's gonna be a lot of questions about types of toothbrushes and fluoride and floss types to use. So you'll want to know how to answer those questions. But you're an educator in the sense that you're teaching them how to maintain good hygiene so that the kids have good habits as they grow older, and that you're able to prevent cavities and different type of oral infections and disease throughout their entire life. Parents are often concerned about the radiation from radiographs, but as you learn in school, the radiation from radiographs are pretty low, especially digital radiographs, which most offices use now. But you'll want to know, types of x-rays or types of radiographs that you're going to be taking on children, the intervals of when you take them. And parents are going to often be asking why it's necessary, so you should be able to answer those questions. In your oral pathology class, you'll probably be learning a lot about different types of pathology. There's pretty common ones that you'll see all the time in a pediatric office. So I'd say the most common ones that we see are enamel hypoplasia, where the enamel doesn't form properly on permanent molars or permanent incisors. Supernumerary teeth, so extra teeth or fusion of teeth, as well as missing teeth. And there's also certain syndromes that we'll see, such as primary herpetic gingivitis, where patients will come in feeling pretty sick, their gums are going to look pretty red and irritated, and you're going to have to be able to answer these questions, or at least have a general idea of what's going on. Once you're in a peds office, you will see certain things come up over and over again, and it becomes quite familiar in terms of identifying it and how to answer it to parents. Orthodontics is a huge component of a pediatric office. We often will send our patients off to the orthodontist when they're ready for phase 1 or phase 2 orthodontics, but we will do space maintenance, whether it be a band and loop, a lower holding arch or upper holding arch. We'll do habit appliances to help prevent tongue thrust, as well as thumb sucking appliances. And we also do expansion appliances in order to widen the palate and to correct cross bites, whether it be posterior or anterior cross bites. Some of the common problems for patients when they're referred to us is having a really bad experience at their general dentist, so they're not able to get the work done at the referring office. Some patients just have such extensive caries that we can't see them while they're awake, so we end up having them go to sleep under general anesthesia, and we'll just fix all the caries while they're asleep. A lot of patients have like pretty bad needle phobias, so a lot of times we're able to mask it, but we don't ever really show the patients the needle. And there's different techniques that RDAs and dentists will use to administer local anesthesia with the patients without the patients feeling it too much. We also have a lot of patients from out of town as well. Like we'll see a lot of patients from rural Alberta as well as Northwest Territories, Yukon, Inuvik, and they'll fly in for their dental care. Thanks so much for listening to my lecture. If you have any additional questions, feel free to email, text, or to call me. Thank you.